So I am going to speak on sex and gender differences in risk prevention and the cascade of care. This is mostly among people who inject drugs. And just a disclosure of having received advisory board fees from Gilead Sciences. I'm just going to start with this image that you may be familiar with, just to be really explicit about what we're talking about here. So sex refers to biological attributes, including physical features, chromosomes, gene expressions, hormones and anatomy. And sex is usually categorised as male or female, but there is biological variation in sex. And around 1 in 100 people have variations of sex characteristics that are outside those kinds of norms of male and female. Gender, on the other hand, refers to socially constructed roles, behaviours, expressions and identities. Gender signifiers and identities and roles are very culture-bound and have varied widely throughout history and between societies. And importantly, gender within an individual is not necessarily fixed, and the personal importance of gender identity to an individual can also vary over time. So sex and gender are different, but they are interrelated, and both can affect health conditions and health behaviours, including impacts on health that are a combination of a sex and gender effect. So one of the most commonly cited examples for how both sex and gender affect health is heart disease. Sex differences in gene expression affect how heart disease manifests in an individual. So males and females present with different heart attack symptoms. And then layered on top of that sex difference, there's this gender difference in healthcare seeking. There's also gender differences in how patients are assessed and managed by healthcare workers. And so these sex and gender differences are a system that lead to differences in outcomes, such that while men are more likely to have a heart attack, women have lower 12-month survival rates post-heart attack. We also know that because clinical trials of medications often excluded females, they're more likely to experience medication side effects than males. We know if you have a medical emergency in a public place, bystanders are less likely to initiate CPR on a woman because they're worried about touching her chest. That has flow-on impacts for survival. And so it's only been fairly recently that these differences and how sex and gender interact to affect health have been taken seriously as subjects of research. But clearly there are very real consequences to not paying attention to sex and gender, including delays in diagnosis and poorer treatment outcomes. And most often these negative effects are experienced by women because research has frequently taken cisgender men or male animal models as the standard and assumed that results can apply to everyone as if men do not have hormones. That said, I think it's really important to say that studying sex and gender is not just about the health of women or females. Masculinity and dominant norms around masculinity can be harmful to health, men's or otherwise, for a variety of reasons. And so studying sex and gender in health is about making sure that research findings are widely applicable and that all people are able to benefit from health interventions and systems. However, because of the way that medical research has historically been undertaken, it is the case that most of the time, and certainly in the context of hepatitis C, when we talk about sex and gender, what we're talking about is improving the situation for women and girls and people who are outside the gender binary. So I'm going to talk about a handful of papers that have presented key findings on sex and gender differences in relation to various aspects of hepatitis C, in particular among people who inject drugs. So firstly, there is that very well-known sex difference, which is obviously not specific to people who inject drugs. Well-known sex difference of spontaneous clearance of the virus. So 20 to 25% of people exposed to hepatitis C will clear the infection without treatment, but this proportion is higher in people of female sex than male sex. And the mechanisms behind this are not fully explained, but generally it's related to sex differences in immunological functioning, inflammation responses and hormones. Pretty much all of the other differences that I'm going to talk about are related to gender rather than sex. And it's important to highlight Before I go any further, that although gender is not a binary, for the most part I am going to be speaking about cisgender men and women and gender differences between these men and women as two groups. And that's because the data that are available are mostly reported in terms of men and women, almost always cisgender. And reporting sometimes uses the terms sex and gender interchangeably, or it's not clear about whether it was actually sex or gender that was assessed, although this is improving. And sex and gender data are also rarely reported disaggregated by other important axes of power, such as poverty, race, or Indigenous identity. So bearing that in mind, and also bearing in mind that these data are specific to people who inject drugs rather than people with hepatitis C more broadly. So work from Adelina Artini and colleagues found that hepatitis C incidence was higher in women who inject drugs than men. So the hazard ratio is 1.2. There is absolutely variation there between studies and settings that's probably linked to samples and things like the average age and duration of injecting in a particular setting. But there's something here about the gendered nature of risk for acquiring hepatitis C. So there's evidence that women may be less likely than men to attend harm reduction services. Women might avoid these services because the social cost of being identified as someone who uses drugs is greater for women than men, or simply because they don't feel safe there. And women who inject drugs are frequently subjected to gendered violence in their romantic and other relationships, and that can also impact on an individual's capacity to access services or constrain their decision-making around drug use. One thing to note, though, in relation to incidence is that even though women who inject drugs acquire hepatitis C more rapidly than men who inject, because hepatitis C is endemic, or at least has been endemic in people who inject drugs, prevalence is actually very similar for men and women within a few years of onset of injecting in most settings. There are some exceptions. This finding, though, is from a fair while ago, and whether this is still true in the DAA era with declining prevalence in many places is unclear. If there are gender differences in the reach or effectiveness of elimination strategies, hepatitis C prevalence may become unevenly distributed. If we talk about hepatitis C prevalence, there's this very strong evidence, of course, that being engaged in opioid agonist therapy is protective against acquiring hepatitis C due to reductions in injecting drug use. There's been multiple systematic reviews on this with very consistent findings and a high level of evidence. So this is the forest plot from Lucy Platt's review in 2017, showing a halving of risk of incident infection while being in OAT. But when you dig into this, there's some nuances there that deserve attention. So the first is that in that systematic review, the authors did a meta-regression on their included studies, examining factors that affected the strength of the association between OAT and HCV acquisition. So they examined a range of factors, the usual things that we look at: housing, incarceration, more frequent injecting. And these were not linked to any important increase or decrease in that association between OAT and HCV. But as the proportion of participants in a study sample that was female increased, the protection against hepatitis C acquisition provided by OAT substantially weakened. And then another study was the INC3 collaboration, an analysis of data from 7 cohorts of people who inject drugs. And in analyses of those data, it was found that hepatitis C incidence while on OAT was almost twice as high in women relative to men. And a second INC3 analysis found that any exposure to OAT was associated with significantly lower hepatitis C incidence in men, but not women. There's limitations, obviously, to these analyses in terms of the measurement of OAT exposure. Any OAT is a very blunt measure, but there's convergence there towards this same finding, that this very well-known and widely implemented prevention strategy that is really a touchstone of elimination plans may be less effective in women who inject drugs relative to men who inject. So most of the results from here on are from some recent work from my team led by Dr. Anna Levinson. This was published last year in eClinical Medicine. That's where Lancet Gastroenterology sends your paper when they're not like super enthusiastic about it, but they really still want to get that exorbitant open access fee out of you. So in this paper, we reviewed publications on hepatitis C risk prevention and cascade of care in people who inject, and just produced summary estimates of gender differences in various parameters. So if we look at needle and syringe sharing, there was no difference between men and women in lifetime receptive needle and syringe sharing. But with those more recent recall periods, there does seem to be something of a difference, suggesting that women may experience more constraints in consistently practicing safer injecting. So there's this layering of gender onto this fundamental risk behaviour for hepatitis C infection, such that some people experience greater risk and therefore higher incidence. We also looked at incarceration history, given that being incarcerated is itself a risk factor for infection. And as you might expect, that was more common in men over any time frame. So here gender is influencing exposure to a particularly high-risk environment. There was quite a lot of data for various stages of the cascade of care, and I've included the full forest plots because I think with these ones it's helpful to look at the overall pattern of study findings. So starting with testing, these were results of studies of community recruited samples of people who inject drugs with lifetime hepatitis C testing as the outcome. So one is the null here, so a study crossing the null would suggest no gender differences, and most of these studies are actually fairly equivocal. So equivocal, yeah. The summary estimate, though, suggests that women may be somewhat more likely than men to be getting tested for hepatitis C. The confidence interval's not entirely above 1, but it mostly is, and that outlier at the top is probably responsible for why it's not totally above 1. So testing is probably higher among women in community recruited samples. And then these were the results for testing for samples recruited in opioid agonist treatment. And I would have thought that being recruited in a treatment setting would mean that gender differences would not be present because everyone would be being offered and having the same opportunity for being tested. But the higher testing among women is actually clearer here. And then when we combine those community recruited and OAT samples, we do see that overall a slightly higher proportion of women report testing than men. So that's lifetime testing, so again a fairly blunt measure, but it is reasonably consistent across studies. But then we have this little switch. So despite higher testing in women, uptake of DAA therapies is higher among men. And that's true for community recruited samples. So most of these studies show this difference, and the summary relative risk was 0.85 in favour of men. And it's true of OAT samples as well, although there are fewer studies. And when we combine the community recruited and OAT samples, so that's 14 studies and about 70,000 people, there's a clear difference in treatment uptake, with men who inject drugs being more likely to engage with treatment than women who inject drugs. And I think most people already knew that to some extent, but seeing this many studies from quite a number of different countries really confirms to me that hepatitis C elimination strategies need to have a gender angle. In looking at completion of DAAs, most of these studies are clustered around the null, and the summary estimate shows no evidence of a gender difference. And I didn't really expect to see one, given that adherence in clinical trials is quite high, but that was borne out by the meta-analysis. And then finally, sustained virologic response. There were quite a few studies of SVR, and you can see they're mostly equivocal with some minor variation, but in both directions. And the summary estimate is 1.02, with women having a very slight advantage, but given that pattern of findings, it doesn't make a lot of sense to say that this is a clinically important difference or even a real difference. You know, one study in the other direction and the result would probably flip. So we have these differences in incidence, in exposure through injecting behaviours and incarceration, differences in spontaneous clearance, and in testing and treatment uptake. And sometimes a difference gives an advantage or a better outcome for men, And sometimes it gives an advantage or a better outcome for women. And we don't really know what the cumulative impact of these differences is as someone passes from being at risk to acquiring infection and then needing care. So if women have a higher incidence of hepatitis C, but spontaneous clearance of infection is linked to female sex, then maybe these two differences kind of cancel each other out. Incarceration is a risk factor for infection and experienced more so by men than women, but incarceration can also mean access to testing and treatment. So maybe that explains why men have higher treatment uptake. But then why is testing not also higher in men? So this is, again, it's this complex system where you've got sex and gender differences at different stages that can create disparities that disadvantage different groups of people at different times. It seems pretty clear, though, that we need to be thinking about this in terms of what it means for achieving elimination and how we ensure that these differences do not compound and reinforce gender inequalities. So that was all about quantifying differences, but what about explaining why these differences exist? And I'm just going to very briefly explore some of the context that underlies these numbers by looking at some qualitative research. This is by no means a complete review of this topic. I've just picked a couple of studies that explore these issues really nicely. So the first is more relevant to prevention. This is a study around access to needle and syringe programs among women in Stockholm. And the sample, it was women who were using the NSP, so who have clearly overcome some barrier. And they were asked about barriers and facilitators to use. And they talked about a few things that are very common in these kinds of studies when people ask about barriers to NSP use. So things like shame and stigma or restrictive opening hours. But then there's things that really clearly show the gendered dimension of harm reduction access. So fears around loss of child custody were really prominent in this sample because in their context to use the NSP, they had to register and be known to social services as a person who injects drugs. Fears around violence and past trauma were also prominent. So going to the NSP might mean running into someone you didn't want to see. They also talked about being subjected to coercive control from partners, which prevented them from being able to go to places independently and exercise their agency to access harm reduction. And there's a few studies that report similar findings, and they really speak to a need for harm reduction services that are gender responsive. And that doesn't have to mean women-only services. It can, but that can be a tall order in terms of adequate resourcing. It can just mean that there's more attention given to gender and designing services that actually take gender into account. So, for example, integrating sexual and reproductive health care is something that women often bring up when asked how harm reduction services could be more attractive to them or responding to their needs. The other qualitative study I want to mention is this piece from Alison Marshall, focused on women's access to treatment for hepatitis C. And again, the findings really speak to the fact that there's specificities to women's experience of disease and care. So this paper really highlights how intersecting social positions as a woman who injects drugs, a person with hepatitis C, navigating drug treatment systems, hepatitis C systems, these really gendered dimensions need attention to ensure equitable access to treatment and care. And this is true not only for women who inject drugs, but also women from other key populations affected by hepatitis C, because it can be as simple as gendered responses to women's healthcare seeking. I'm going to finish by talking a little bit about data collection in face-to-face or phone interviews, surveys, study visits, etc. I wasn't sure if this would be a bit boring, but we'll see. So, as I mentioned, your researchers have not always been clear about whether they're reporting sex or gender and how they've ascertained these variables. So Statistics Canada has data standards with regards to collection of sex and gender identity, and their position is that gender is the primary question for surveys of social issues, with the sex question included where biological characteristics are important to the topic at hand. So for gender, the options in the standard are man, woman, or non-binary person. These can be combined with the sex at birth variable to define people who are cis or transgender. This is a fairly limited number of gender descriptors. You can, of course, allow an option like prefer to self-describe and record what people say, but I remember being a research assistant and having to clean data sets with write-in responses, and just don't do that. So there's also a version of this standard where everyone's classified as cisgender, transgender or non-binary. I think that's still fairly limited and kind of hard to combine with the sex at birth variable. But this paper by Greta Bauer and colleagues is a good examination of various response options and how you can combine sex and gender variables. So for sex, it is important that the question specifies sex at birth. And there's two versions suggested by Statistics Canada. So a version with just male or female and a version with male, female or intersex as well. And Statistics Canada make two really important points with regards to collecting sex at birth. First is that the wording of the question can influence how a person responds, hence why at birth is recommended. And secondly, that the order of the questions can also influence the response given. So ideally, we ask about gender first because that's what is most salient to most people. It's how they present themselves to the world. And then we ask about sex by saying something like, because some aspects of hepatitis C are affected by your sex, we need to also ask about your sex at birth. And that ordering of the questions and that little disclaimer is important so that people are not made to feel that their gender is being called into question somehow by referring to their sex. And then, of course, that's very much the micro level of sex and gender in hepatitis C. And there is a lot more to do than just improve data collection. And I don't know, so gender is culture bound, right? But acknowledging that gender is culture bound is also culture bound. And so I've stood up here and I've assumed that everyone here is on board with the sex and gender are different train, right? But maybe you're not. And it's not that uncommon in Canada for people to hold the view that gender is determined by sex. So these are data from a representative population sample in 2019 with 1/3 of people saying that gender and sex are not different. And this is more recent, 2023, another population sample including people who identify outside the gender binary being oversampled, and only 1/3 of respondents endorsing the idea of gender outside the labels of male and female. I do think that's a really badly worded question, but the general point still stands. And then, of course, science in a whole range of areas is under attack in the US, including but certainly not only sex and gender science, and that is where a lot of the research funding comes from. So I don't have any answers to the problem of fascist creep. Fascist creep consensually, not like the fascist creep. But it is really important that we continue to bring attention to this area in hepatitis C and other infectious diseases and health of vulnerable populations. So understanding the cumulative effects of sex and gender differences in hepatitis C risk prevention and the cascade of care requires further work. There's a lack of data on people from gender minorities and gender in relation to other social positions. That said, I think it's really important to acknowledge that data on binary gender are more valuable than no disaggregated data at all. Applying a gender lens to the design and implementation of interventions is probably going to be an important step for accelerating elimination efforts. And I'll just put in a shout out for the potential for collaboration with our colleagues in the social sciences to better understand these issues. And when I say that, I don't just mean qualitative research, or that is also an important part of it, but I'm really talking about kind of getting into some theorising and getting to the heart of why it is that some people are being left behind in elimination efforts. So yeah, I believe that's all. Thank you so much.
Thank you, Sarah. Right on time, so we didn't have to zap you. So any questions? We have time.
I'm not under speaker. Okay. Hi. Thank you. That was great. And even the part that you said might be boring was not boring. Everything that you talked about is really, I'm with Action Hepatitis Canada, and everything that you're talking about is really interesting to us right now. My only question, when you were talking about not a big difference between men and women sharing needles, I'm interested in the difference if they're like scientifically, if when you ask people if they're sharing needles, if there's a difference between being the first user or a second or further down the line user.
So I'll just speak to this is not work I've done, this is again literature. So what we showed was that over the lifetime it sort of evens out, but in those more recent time frames there is evidence for women being more likely to report riskier injecting, which does seem to suggest that perhaps it happens more frequently for women. And yeah, there's definitely a lot of the qualitative work around how when women are injecting in heterosexual partnerships, they are usually the second to inject. There's the power dynamics around acquisition of drugs and things like that, yeah.
Okay, thanks.
There's a question over here.
Right. See, I learned my lesson after that.
You're a smart man.
Yeah. Well, just slightly smarter than average, which is actually still pretty low because I am a man after all.
I thought I was really doing a good job of not trying to make men feel stupid.
So I may have missed it, but and I know the literature is divided into just binary male-female, but was there any indicators in the literature about your data on women getting tested less and men taking up treatment more? What's the situation for the other category, the people who refuse to answer the gender or who identify as other? Is there enough literature to make any preliminary conclusions?
It's really hard because most samples, if you start with a sample of people who inject drugs and then want to look specifically at people who are transgender or gender diverse or indeed don't answer the question, you get to very small numbers, and of course you can't really say much. And then, I don't know, Peter, has there been anything like has anyone done I don't think anyone's done a meta-analysis. Is that what Jack's doing now?
No, but you could look at surveys of transgender people and see whether they're getting tested.
Yeah, Peter told me that yesterday to put that in my grant that's due on Wednesday. So, so yeah, starting with samples of transgender people and then looking at injecting drug use. But yeah, I think that I think broadly speaking, we can understand higher prevalence of things just in relation to various, a constellation of risk factors. But
Sarah, I'm really glad to hear that you put that in your grant because...
I haven't done it yet.
Well, please do. So, we've just been going through this process in BC, to create our BC HEP elimination roadmap, and the working group that was specifically looking at recommendations for women and gender diverse people highlighted that they found a lack of literature and evidence around specifically hepatitis C risk for gender diverse people, so people who aren't fitting into that binary, and that there was a couple of limited observational studies that they found from the US, but not the same context here. And so it is a really, I think, important gap to address in our understanding in the literature, given, I think, what we know about gaps in care for that population in general. So a call for everybody, but also thank you.
I'm going to try and put it in the grant. I'm really tired.
Thank you, Sarah. We'll stop there so we can stay on time. Thank you.
Thank you.